Cast is now starting. All attendees are in listen-only mode.
All right, welcome everyone to this very special November 2019 edition of the Pre-Hospital Care Research Forum Journal Club podcast. We'd like to take a moment to dedicate this episode to all of the men and women who have served and are serving our country. We have selected today's article with our military service members and veterans in mind, as we'll be discussing some important characteristics related to mental well-being. Thank you again and happy Veterans Day to you and your families. As a reminder, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here, with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Rimley Crow, and today I'm joined by Dr. Tony Fernandez and Dave Page, who's a little laryngeally challenged at the moment, but will be texting in, and Bill Toon. Today, we're going to be reviewing an article entitled The Relationship Between Grit and Resilience in Emergency Medical Services Personnel, and this was published in the Ochsner Journal. As always, this review is paired with an article written by our own Dr. Tony Fernandez in EMS World called Journal Watch. We encourage you all to check out this article at emsworld.com under the category of education and training. So thank you all again for joining us today. And as we begin, we want to remind listeners that you can always use the chat feature on your screen at any time to type in questions and comments, and we'll bring those into the conversation as we go. With that, I think we can go ahead and dive right in. I'll start by talking about the objective of this paper, and that was to examine the relationship between this concept of grit and resilience, specifically as it relates to PTSD among EMS personnel. And the authors hypothesized that higher grit would be associated with lower PTSD. And they also thought that grit would be related somehow to these coping mechanisms that we're going to talk about in more detail. But before we just dive right into the topic, I thought it would be great if Tony and I could talk a little bit about how we arrived at selecting this topic and why this topic matters. So Tony, can you tell us a little bit about why we thought it would be important to highlight this topic in particular?
Absolutely. Hey, Remley, and I hope you're having a good day today, and thanks to all listeners for joining us today. I think this is an incredibly important topic. We know from the literature that anywhere from 9% to some estimates of 22% of EMTs and paramedics develop some symptoms of PTSD, and we have a tough job. We know that there's been more and more reports of suicide among our colleagues, and some of us have experienced that in folks that we love, and we are looking for ways to identify that and see if we can intervene early. And I think that this paper is one of a few things in the literature right now that kind of strive to head in that direction. There is
absolutely, and I think that.
Please.
I was just going to say, I think that this article was important because it's taking a positive approach to one of these things that can be so negative. So we often talk about all that's going wrong, and this article really set out to look for something protective, so something positive that, upon learning these findings, we may be able to implement that would have a role in protecting us against things like PTSD and other negative mental well-being indicators.
Yeah, and grit to me is it was a new concept. We got to learn a little bit about what grit means and how it would relate to what we do in our field. And I think the authors were on point using this measure to identify PTSD and speak a little bit to how that affects folks in our field.
Right, and so I think that's a great point, and maybe a good place for us to get started is just talking about, what are these variables that we're looking at here? So we say something like PTSD, and we all kind of have an idea of what it means, but perhaps it makes sense to spend a little bit of time talking about exactly what is PTSD and, how's it different from some of these other mental well-being indicators that we talk about a lot, like burnout or depression and stress and anxiety. And so I looked up a little bit about this because I was interested myself, just how does PTSD get diagnosed, and is this scale, this PCL5 that they're using, actually measuring these variables? And I was surprised to learn it seems like there's 8 different criteria that need to be met in order to diagnose PTSD according to the DSM-5. And the DSM-5 is that Diagnostic Statistical Manual of Mental Disorders. And so we do have PTSD. It's included in trauma and stress-related disorders. And some of the criteria that were included were something that I was pretty familiar with. So like stressor, there has to be a direct exposure or witnessing the trauma. And then criteria B had to do with these intrusion systems. So we often talk about how you're having these unwanted memories or even maybe nightmares or flashbacks after witnessing a particularly traumatic event. And then criterion C is this avoidance behavior, which is trying to avoid trauma-related stimuli. So maybe that looks like withdrawing from work. And then another criteria was these negative alterations in cognitions and moods. So sometimes that has to do with inability to recall features or this feeling of isolation. Then we have alterations in reactivity, sometimes symptoms like irritability or aggression, risky or destructive behavior. Also, they talk about this in the study related to some of these unhealthy coping mechanisms. And then there were some more of the physical manifestations like difficulty concentrating or these sleep disturbances, either sleeping too much or not sleeping enough, not sleeping at the right times. And something key here that I found in this diagnostic manual was the duration. These symptoms need to last for at least 1 month in order to be considered PTSD. And then the last criteria that I wanted to mention was that there's an exclusion that's required, and that's that these symptoms can't be due to medication, substance use, or other illnesses.
So that's really important and helps us kind of understand how we, where we are and how we start down this road of if we want to know what exactly we're measuring, and their outcome here was PTSD. So I think that's some important information. Thank you, Emily.
Right, and I think it's important just to talk about how, this is something that has a diagnostic code, and it's different from other things. This is directly attributed to some sort of traumatic event, whereas something like depression, anxiety, and stress does not necessarily have that identifiable exposure. And then when we talk about something like burnout, burnout doesn't have a DSM-5. It is included in the ICD-10s, but it's included as a workplace phenomenon. So it's something that, the provider attributes directly to their work, but it's not something that's affecting other areas of life. PTSD is something that's quite severe and permeates all areas of life, and that's something to keep in mind that, this isn't just on the job stress we're experiencing, we're taking this home with us.
Yeah, so when we're talking about predicting PTSD, we're really talking about an outcome that's really affecting folks who are the worst affected among us.
Absolutely. And so the converse of what we were looking at here, so PTSD is the outcome for most of these analyses, but then there was this concept of grit that they looked at. And I, like you, this was new to me that there was a scale and actually a way to measure grit. And when we hear it, we kind of have an idea of what it is. But here the authors specifically defined it as having 2 sort of components. It's this ability to sort of stick with it, a consistency and interest or passion for a long-term goal. And then the other component was this persistence of effort in the face of adversity, so perseverance. If obstacles come up, the person continues to pursue that same long-term goal and doesn't just abandon ship.
Yeah, so it's an interesting concept. Grit. It's not something that I've seen measured very often, particularly in EMS research, and I think I can understand the author's hypothesis that this would be related to less likelihood of PTSD. So I think it's a good hypothesis, and I'm interested to talk about the results. But before we get there, I think we should obviously explore some of their methods.
Absolutely. I would like to give a chance to contribute. I know that we invited another special guest over, so Mike Hagman, thanks for joining us.
Thank you for inviting me to participate.
Absolutely. And so wanted to check and see, do you have any thoughts on the importance of this concept of grit before we dive right into the methods?
Absolutely. I think that there's a whole body of research and science around the concept of resilience, of which grit is kind of a subset a little bit. So resilience has got a little bit of a broader construct than grit does, but grit is certainly a key piece of it. And I just wanted to say a couple of quick things about PTSD. The one, and I know we're going to get into methods here in a second, but one of the challenges is that, and particularly if you look at EMS groups on Facebook and whatnot, there's a whole lot of self-diagnosis. And I really appreciate you walking through the DSM diagnostic criteria. You need to have those symptoms persisting for 6 months, really, to get the DSM-5 diagnosis. And there's a whole lot of what is kind of self claimed PTSD that may not be PTSD in our world. And that in addition to big events, there's also a concept where you can experience vicarious trauma, and there are some diagnoses of PTSD that are legitimate, that can even be from family members of people who are exposed to chronic, persistent, ongoing stressful situations that can be a legitimate diagnosis that don't necessarily tie to a big event.
Absolutely, and those are some important points. I know that the authors, I thought, did a very good job at picking a scale that measures true PTSD versus just some of these self-diagnoses and feelings of it. It's a hard construct to capture, and I was actually pretty surprised when I looked up the DSM criteria on how many different criteria have to be met. And
Yep.
I think that any measure, we have to understand what it is we're looking at. I know that you have some interest in resilience engineering, so I'll be interested as we get into the discussion piece of this article to talk a little bit about, how can we engineer for resilience and improve that.
Absolutely.
All right, and I think Bill Toon, we also have you on, want to give you a chance to talk about anything just in the introduction and background on this before we dive straight into the nerdy portion of the event. He might have gotten muted, but that's okay. And Dave Page has contributed via text and wants to mention this idea of, grit research can be difficult because a lot of these inventories are proprietary and there's a cost per administration. I think that's an important point in something like this with PTSD. We want to use these validated instruments to allow for consistency and comparisons over time. At some point, this can be difficult to do, specifically when there's proprietary instruments. And we may talk a little bit later. I do a lot of work with burnout, and I ran into the same issues, that one of the most widely used scales is proprietary and cost per administration. And, that was something I didn't want to use for EMS. I wanted people to be able to repeat the work. And I think that the same goes here. We need to pick scales that we're to be able to replicate and that aren't cost prohibitive. So thanks, Dave. And without further ado, Tony, I'll let you take it away.
Oh,
All right.
I'm here. Wait.
Oh, hey, Bill.
Hey.
Right on time.
It must be because Dave has subconsciously had the mute me away from everyone else. He does that. So. And I know he can't defend himself now since his voice is troubling.
Yes.
So I'm taking it to my
Best time to talk about somebody.
Yes,
Exactly. When he can listen and can't respond. So
Exactly.
I really appreciate what Mike Tagman had to say, and that I know that he's been echoing the same kinds of things on the Facebook page, because I want to make sure that we develop, as we look at this topic, it is an important topic, but what we need to do is find what it is really mean for EMS providers, and how do we get them to get properly diagnosed, to get the help they need, versus a lot of unsubstantiated or unfounded type stuff. So it's taking the emotion out of it and getting them the help. And I know this may be something that people don't like to hear, but it's important that we put some of the factual aspects of it. And that was one of the things I did appreciate about reading this particular article and stuff, is their effort to, to put some evidence behind what they had to talk about. So, but I look forward to our further.
Well, thanks for joining us, Bill. We always appreciate your insight. Yeah, so let's we'll go ahead and jump into some of the more nerdy parts of the research here. So let's talk about the methods, and specifically, let's talk about where they did this and when. So this was a survey. As we were talking about things that can be cost prohibitive, the investigators certainly couldn't go out and try and diagnose everybody either with PTSD or not. So they sent out a survey with some validated instruments, and they sent it to the East Baton Rouge Parish Emergency Medical Services, and it was an email survey. They sent the survey out from June 2017 to August 2017, and they sent a reminder email at the end of June for participation. And I want to stop here and talk about why it's so important, especially for something like this, what we're measuring here, to have a short time frame in your surveys. There are some things where you can stretch a survey out for maybe even a couple quarters in a year, but for something like this, where we're measuring PTSD and we're taking a snapshot, essentially, you want to make sure your time frame is short, because there could be things that happen in EMS in the field, or something like a terrorist attack that could really skew your numbers. So you want to keep this nice and tight, and I think the authors did a good job there.
Right, I think that's important too. Even just turnover at an EMS agency is an important piece. So it is important to have that short turnaround time on a survey, and I think that the authors did well to include that reminder email.
Yeah, absolutely, because as we know, how many emails do we just have every intention to getting to until we get that reminder, right? So I'm sure that boosted their response rate quite a bit. So they do talk about how this was an anonymous survey. It was voluntary, so there was no, and they made the point to say that not only was it anonymous, but they had the inability to capture IP addresses, which I thought was certainly a good thing to mention. That's not often described in all survey research, particularly that's a way to maintain anonymity.
Right, and this is crucial for a topic like this, where there is some sensitivity around it. It's a health outcome, and so people might not be so willing to report their innermost thoughts on something like this topic if it weren't anonymous. So I do think that is a key feature.
Absolutely. And they do talk about how they have IRB approval, which we've talked about before. It's important to do that to protect your subjects, and really they likely wouldn't be able to publish the results without it. So let's move into their measures. So obviously they collected the basic demographics. You'll do that in most surveys, age, race, gender, and the like. Let's talk about how they identified folks with PTSD and how they didn't. They used a checklist for this. I believe this was one of their validated measures, and they call it the PCL5. It's a PTSD checklist for the DSM-5. That was their outcome of interest, and then they included the grit scale, which we'll talk about, and a brief cope scale, which we'll also move into. And the last thing that they included was the professional exposure to traumatic experiences scale. And this, they made a note that it was modified from another checklist, which is called the life events checklist. So when we talk about the demographics, I mentioned some before, but they included sex, age, and years on the job. And they categorized age by the decade of life. So in other words, they cut it into 10-year categories. So I will move into what the PCL5 is. This is a 20-item scale. And on this scale, items are ranked from 0, which represents not at all, to 4, which is extremely. And they asked how much the individual has been bothered by these PTSD-related symptoms within the past month. Higher scores indicate more self-reported PTSD symptoms, and then we talk about some of the internal consistency and the reliability of the test, which is those are the numbers they present lead you to believe that this is a good test to use to identify PTSD. That was their outcome of interest, and then they also, for their independent variables of interest, the first one that they looked at was the grit scale, and this was a 12-item scale. It has 6 items assessing consistency of interest and 6 items that assess perseverance of effort. So they included items that were similar to my interest change from year to year, or I often set a goal but later choose to pursue a different one. Items related to perseverance included things like I finish whatever I begin, and setbacks do not discourage me. This was a 5-point scale, and 1 to 5, and it ranged from not at all like me to very much like me. And higher scores indicated that the individuals had higher self-reported grit. We'll move on to the COPE scale now. So this was a brief COPE scale. Now they say brief, and I'm going to stop here and just, we're going to talk about survey methodology in a second, but I've already told you that the PCL5 scale had 20 items, the grit scale had 6. The brief COPE scale had 28 items. So we're already getting up there in number of items we're asking these folks to answer. 28 items rated on 0 to 3 scale, that I do not do this to I do this a lot. And examples include I turn to other activities to take my minds off things, I get emotional support from others, I get help and advice from other people. And these items are categorized into 14 scales of 2 items for each. So self-distraction, active coping, denial, substance abuse, use of emotional support, use of instrumental support, behavioral disengagement, venting, positive reframing, planning, humor, acceptance, religion, and self-blame. So again, higher scores on this scale indicate that the individual is more likely to use a coping mechanism. And then finally, they used, and we're getting up there in, again, number of items here, the professional exposure to traumatic experience scale. This was 11 items on this scale. And the first responders, it asks 11 items that first responders may be exposed to. So serious accident at work, sudden or violent deaths, including homicides and suicides, fire, explosions. So this was essentially to identify the traumatic event. And higher scores indicate a higher frequency of self-reported exposure to traumatic events. So, Remily, can we talk about how the burden of asking your respondents? I think we're up to 4,000 questions here. No, we are up there in 70.
Pretty close.
Yeah.
I think that is a key piece to survey methodology, especially with our attention spans, and maybe grit is related to finishing the survey. So that's here. Yeah, I thought you guys would like that. Yeah, no, but I think that this is a key piece of survey methodology when we're selecting the measures. I mean, there's obviously we want to measure everything, we want to measure it well, but there's a trade-off in the attention span of the person taking the survey, and we can expect that, you know, people who are burdened with these mental health symptoms are not going to want to sit down and take a survey. So we do have to keep this as short as possible and still measure what we're looking for. So clearly the outcome is non-negotiable. We have to measure the PCL5 if that's what we want to choose as our outcome. But then when we start to get into these longer other inventories, it might be valuable to look at, you know, do we need each of the elements on this COPE scale, or is there certain coping strategies that we're more interested in than others might be an option. Another important feature on the survey might have been if they could have randomized the order of the scales so that you're not getting, you know, people just finish the top 5 and then kind of abandon the survey. There's a lot of different strategies to get at this, particularly when you have a larger study population, but this was a survey of a small one single service, and so they didn't have a lot of those options available to them, but that would be something to consider for future work.
Absolutely. So I'll go ahead and move into some of the analyses that they did. And let's talk about, so initially they calculated descriptive statistics. Wait, please.
So a question that was interesting, and I know they break this down, the number of surveys sent out, who completed all of it. And I think Remley nicely touched on it about the fatigue factor that would even come in, or the grit they would need even to complete the survey. But they probably, and I think the number that they had there that did complete, I thought was fairly high. So they're obviously, it was an important topic to them. So I think if it's important to them, they're likely to make greater effort. Now, again, you can incentivize people also to complete surveys, and that's often done in consumer research and everything, is they incentivize it to get people, particularly the longer surveys, to get them to commit to spending 45 minutes or so to complete the survey.
Absolutely. I think you just brought up a really important point there too, Bill, with the interest in the subject matter. So this is a key piece of survey methodology as well. Do you reveal the topic of the survey in the email? If I send out a survey saying, tell me how burned out you are, I'm probably going to get people who are really interested in burnout one way or another. So the extremes, versus if I just send out a survey with, kind of open title like EMS workforce survey, I might capture a more neutral audience. And so that becomes important when we start to move into the results in a bit, where we see the response rate and we start to consider how can those who responded perhaps differ from those who didn't respond. Excellent.
Yeah, absolutely. And certainly if you only survey folks who are have some kind of relationship to the topic or feel strongly about the topic, you may have a biased sample. So it's doing a response or non-response survey is often important. The authors didn't talk about it here, but it is important to see how those who responded in your survey differ from the rest of the folks who could have responded, and just the general population overall. All right, so I will move on to statistical analyses. So we talked about descriptive statistics, and you see these with all research topics. These are your frequencies and your percentages, and obviously they calculated those. They also used a Pearson correlation measure to measure the relationship between demographic variables, professional exposure, grit scores, and the PCL5. And the Pearson correlation measure, it's a measure between -1 and 1. And you're essentially, if you're up at 1, the relationship is there's a positive relationship. 0 means no relationship, and then -1, there would be a negative relationship. They also use linear regression to determine whether the demographic variables or professional exposures predict grit scale scores. So linear regression, we often talk about logistic regression. And logistic regression, as we talk about, it has a binary outcome, either you lived or died. Linear regression uses a continuous outcome. So, and it makes sense to do that for things like scores, where there could be a difference between 1 and 2 might be an important difference. So you'll use linear regression for continuous and logistic regression for dichotomous outcomes. They also, finally, they use linear regression again, except they did what they call a hierarchical linear regression. And the idea for this is they've used the brief Cope scale score to predict PTSD, but they wanted to see if adding the grit scale score to that, it described the relationship in PTSD a little bit more. And the way to do that would be to adjust for grit when assessing the Cope score, and that's what they did. They added that to the model. And what's really important, as we'll see, this isn't the largest sample size. So they did conduct a power analysis to determine what if there was a difference, how powered was their survey to actually detect the difference if one was there. So we'll give a little results away early, but their power analysis indicated that if they had 15 predictors in their linear regression model and a sample of 84, which is the number of folks who actually completed the entire survey, they had a power of 90 to detect what they call a large effect. So they were powered to detect the difference if one was there. And as we see with most other research, they set their significance level at a p-value of 0.05. So if there's no questions about the results or how they did their analysis, I think we're ready to move on to, or the methods, excuse me, or how they did their analysis. I think we're ready to move on to results.
I think so too. There is one just key feature I want to point out as we go into this kind of analysis, and that's, they used correlation and they used linear regression, and all of this is looking for that straight line relationship. So if there were not results here, that doesn't mean that there's no relationship between these things. It just might not follow a straight line. It could be, an exponential curve. There can be the U-shaped curve. We should keep these things in mind just as we take a look at the methods, and just keep them with a critical eye there as well.
Definitely.
All right, I think we're ready. Let's look at the good stuff. We can start off with table 1 and talk about what we see. Table 1s are typically just who's in the study population, who is in our analysis, and we should keep in mind who's here as we think about who the results of the study are going to apply to external from the study, or if they will.
Yeah, absolutely. So we can see that there were more males than females. We see this often in EMS research. Overwhelmingly Caucasian. It did seem to be it looks like about a third of folks were 31 to 40, and then there was another third that were 41 to 50, and the rest were dispersed between the ages of 21 to 30, 51 to 60, and over 61. We did have almost all paramedics, and I think that'll be important when we talk about grit going forward. And this was a very experienced population. If you look at years on the job, there were over half of the population that responded had more than 15 years on the job. So that's, again, something we're going to want to keep in mind as we interpret these results going forward.
Absolutely. I think this is a more experienced population than what some of the national surveys have in terms of years on the job. And this concept of having 92% paramedic, I think, is important as we think about, do these things like grit and resilience differ by certification level? And, we could talk about some of that in the discussion, but I think that is important to keep in mind.
One other thing that just pops up for future research is that it'd be interesting to gather a history of military background since today's Veterans Day, and also in gathering that one, whether or not people saw combat might be an important variable in analyzing data on this topic.
Absolutely. I mean, there are. Remley and I were discussing this offline. There are a few variables that I do wish they would have included as well. We don't know much about the agency or how many calls they respond to and the types of calls they respond to, and I think that would be that would certainly be relevant here as well.
Yep.
All right. Well, are you ready to dive into table 2, Tony?
I think so. Let's take a dive. All right. So
this is our correlation between the PTSD outcome and the other two scales, one looking at grit and one looking at these coping strategies. So I'll let you take it, Tony, and tell us a little bit about what's a negative correlation mean here when we see this total scale score, and what about the strength of that association?
Yeah, so stick with me here. I know this this table is a little complicated. Let's start with the easy stuff, the stars. The stars show the level of statistical significance. So you can think of one star as being moderately significant, and 3 stars being very, very significant. And how that works is actually 1 star was a p-value of 0.05, 2 stars was a p-value of 0.01, and 3 stars was a p-value less than 0.001, excuse me. We talked a little bit about correlations before. So 1, it goes from -1 to 1, and negative is going to reveal a negative correlation. So as your scores on one go up, your scores on another go down. 0 means no correlation, and 1 means a perfect positive correlation. As your scores go up on one measure, your scores are going to go up similarly on your outcome. So, and this kind of describes that, and I'm glad that they put this first one here. They look at, and if you look at the first row and the column all the way to the right, they go total grit score, and there would be something really wrong if total grit score didn't fix total grit score, but they do, and it's 0.1, it's 1, so that's a perfect correlation there. And you can see that your grit score, there's a negative correlation with your PTSD score, which is your PCL5. And that's highly significant. And as we go down, they broke out each section of the brief COPE scale score. So we have self-distraction, active coping, denial, substance abuse. And you can see which ones of these have a significant relationship. There are a few: self-distraction, denial, substance abuse, emotional support, disengagement, venting, and self-blame. Those all had a significant relationship, either positive or negative, with your PCL5 score, which is again predicting your PTSD. If we move over one column and we look at predicting your total grit score, self-distraction, active coping, denial, substance abuse, disengagement, acceptance, religion, and self-blame all have some relationship with your COPE score. I'm sorry, with your total grit score. So, and you can see if they're negative, again, that's a negative relationship. If they're positive, that is a positive relationship, and 0 is no relationship at all. So I think what here, there are a couple that were related to both. And we'll self-distraction, denial, substance abuse, and disengagement and self-blame were actually related to both your PCL5 score and your grit scale score. So those are certainly interesting things that we may want to pursue going forward.
Right, and I think something here important to note is the strength of the association. So when we're looking at epidemiology papers, we consider, like a 0.3 on a correlation is considered to be pretty strongly related, and we're seeing some effects near 0.6. So these things are very strongly related with the PTSD scale. So things like this disengagement and self-blame in particular caught my eye, as well as substance abuse. And those things that are most strongly positively correlated to the PCL5 or to PTSD were negatively correlated with total grit. So the authors do appear to be making a case for this argument of grit appears to be related to more positive behaviors, whereas these negative coping strategies tend to be related to the more negative outcome of PTSD.
A great point. So if we don't have any questions on this table, I think we can move on.
All right, let's look at table 3.
All right, so this is the final regression model. And again, here what they did was they used the components of the COPE scale and they added grit to the model to see how important that was. And as you can see, not everything in that initial list was significant in the regression model. So if we look, we'll start over here at the p-values on the right-hand side, and you'll see that if we're looking for a cutoff of 0.05 for significance, there were only 5 things that ended up being significant. We had disengagement, self-blame, total grit scale score, substance abuse, and denial. There are the first 2 columns. That's probably out of the scope of this call to explain these first 2 items, but they are the coefficients that you would put into your regression model to determine how the slope of your line changes. So there were some things that were interesting here to predict PTSD. Disengagement, I think we can that one is a pretty common symptom that we may understand. Self-blame as well. It was interesting, and it looks like their hypothesis and that total grit scale score was related to PTSD, substance abuse, and denial. These are pretty much things that I think we may have guessed. There are some things that were interesting that were not related. Things like acceptance, active coping. These things ended up not being related in the multivariable model, which is I was interested in that.
Absolutely. And I think just to remind folks on how to interpret these coefficients kind of in an easy way is for every 1 unit change in, let's just take total grit score. So for every 1 unit increase in grit, we see a 0.29 point decrease in our PTSD scale. So if we're looking for things to reduce PTSD, we'd be interested in these variables that have the negative sign in front of them and that are also having a p-value below 0.05 if we're 0.05 level people, which I am not.
None of us should be.
Yeah, so we see the things that come out here are this total grit scale score, denial, which was interesting to me, planning, emotional support, and religion, and self-distraction are some of these things that weren't necessarily surprising. Now, with self-distraction in particular, I may not be a 0.05 level person, but 0.978 tells me there's probably no relation there.
Yeah. Agreed.
And so with that, I think we can take a second and turn it back over to our panel. I'd like Bill and Mike to weigh in on what does this add to what we know about PTSD, and how should we be taking this into practice, or should we not be?
So I have a couple of thoughts, and I think that there's a preponderance of research, at least 55 studies that I've looked at so far, on the topic of resilience, which is related to grit, as we described, and there's a pretty clear correlation that people who have high grit, high resilience tend to have lower PTSD scores. If you look at the other data, they also have lower OCD scores, lower depression, lower anxiety, and lower suicidal ideation. So kind of a comprehensive look from that perspective, and I think this study reinforces and aligns well with what a lot of the other science says. And there's a phrase that's used in neuroscience with disengagement being the top of the list here. The phrase is, our brains are wired for connection, but trauma rewires them for protection. And that kind of protective mode is one of the manifestations of PTSD, and really shows up in that disengagement, because if you're protecting yourself, that distancing yourself from other people is key. And certainly when you work with people with PTSD, the loneliness and separation is one of the hallmarks. So I'm excited to have this study added to our literature, because it certainly aligns with a lot of the other stuff that's out there. And I think the thing that pops up for me is, if grit is protective and resilience is protective against PTSD, and the question that hasn't been answered anywhere that I've seen if we work with people to help raise their grit and help raise their resilience, does that raised grit offer the same level of protection as people who kind of come with their own grit as opposed to having it developed for them? So I think that's a question for further exploration.
Yeah, I think that's a great point.
No, I was just going to say I like that, Mike, and that brings me, what's the environmental impact, the old nurture type issues, things, or leadership? Are you born a leader or taught a leader? Meaning, do you have grit already? It's just part of who you are, or can you develop grit? And we all know that if there is something to resiliency, is how do we instill that resiliency in a good manner into future practitioners, regardless of what profession they're going into? If it's one that can create or lead to a mental health issue, then how do we better prepare them? That has wide-ranging implications if we're able to do that or find that secret sauce.
I love that. I think both Bill and Mike have just hit on an important point that we're talking about modifiable versus non-modifiable characteristics. And this paper does provide some evidence that things like grit and resilience are probably modifiable. While these characteristics didn't come up in any of the tables, but I think that it's worth mentioning, they did look at the correlation between PTSD and their demographic characteristics. So they looked at things like, was PTSD related to years on the job, gender, or exposure to traumatic experiences, and they didn't find a significant relationship. The only thing that was significantly related to PTSD was as age goes up, the PTSD scale went down. But when it came to grit, this was related to age, years on the job, sex, or exposure to traumatic events. So this makes a case for there's probably some modifiable factors here. And, one of the pieces of my work with burnout has been heavily focused on a systems approach to these conditions that we so often attribute, hey, individual, you need to be more resilient, you need to do some yoga, you need to be more balanced. But really, there may be some things in the system that we can change to help our providers exhibit these behaviors, whether that's, training, looking at some of the job demands and resources that are affected with this. I think this opens up the research to go in a whole nother direction, looking at these as characteristics of EMS agencies.
Absolutely. And when you look at kind of overall stress, which grit and resilience, part of the thing they bring to you is the ability to deal with both chronic and acute stress. There are a whole lot of things in the structure of many EMS agencies in our world that create additional stress that's unnecessary. We tend to focus on the big bad calls because that is easy. But when you really look at people who are suffering, the military refers to them as home front stressors, and things like annual performance evaluations or employee of the month clubs or, supervisors that, don't have empathy or whatever it is. There's a whole lot of, kind of leadership and business practice things that create what's referred to as threat stress that is not necessary, not productive, not core to the mission. But really takes its toll on folks who are already dealing with a lot and taking care of patients and running calls. So I think that there's a lot we can do, not only helping individuals develop resilience, but helping our teams and organizations do it through changing some of our leadership practices.
Absolutely. And we
I'm going to echo yes to that. Having been the victim myself of what he's talked about, but many people, providers that are actually practicing the field, can relate to that. And I'm sure in the course of my history of growing, I've been guilty of contributing to that stressor, and I feel bad for anyone that I've done that to.
Absolutely. I think this is showing this turn in attitude towards, even with a concept like burnout or this concept of PTSD, the attitude may have traditionally been something along the lines of, oh, well, you just weren't cut out for this job, or just suck it up. Whereas this is starting to turn the table, and we're starting to think about this in a different light, and that, you know, this isn't an individual's problem, this is all of our problem.
Absolutely.
Now, we did have a question from the audience. Answer. This is from Aaron. He's asking, you know, on the COPE scale, how was denial defined? And I think this highlights an important point of we should be looking up the instruments that are used, especially when they're publicly available. Not all of the instruments in the study were publicly available, which is important. But this brief COPE is from the University of Miami, and it's available online. So the two items related to denial specifically were just, I've been saying to myself, this isn't real, and I've been refusing to believe that it has happened. So again, great question, and really great idea to dig into the measurement tool.
So one thing I'd like to say, because I know we're coming to winding up here soon, is that I think that is there concerned about the self-report aspect of this research, that it was all self-reported, and there wasn't an opportunity, not that I'm aware of, but I read, where they took a sample of the people and a professional went through the questioning and was able to do some interpretation. Because there's, you know, the value of going and seeing a trained therapist is their ability to work their way through the chaff or the chatter in the background to really hone in on something versus just, you know, you feel this way, but it's not correct feeling. So that, to me, you know, says, okay, this is interesting. It's one study. It does trend towards other stuff that has been done, but it's you know, it's not the one end all or be all to this, because of, I think, some perceived shortcomings that may exist, but still it's nice to see it done.
I think that's also a really important point there, Bill, on these, you know, self-report inventories. For certain measures, sometimes the self-report inventory is one of the only ways. There isn't necessarily, for example, a diagnostic test for burnout. You can't spit in a tube and then I tell you how burned out you are. But these self-report inventories are proxy measures that help us assess the situation, but it's so important to have different looks at different angles at these kinds of things. So this study should get us starting to think about, well, what other kinds of outcomes might grit or resilience be related to? And something that came to mind for me is, you know, thinking back to this conservation of resources theory, people who are feeling run down from their job might be less likely to stay on the job. So I wouldn't be surprised if we find out that these variables are related to turnover, not only from the job, but from the profession. And I also wouldn't be surprised if these outcomes turned out to be related to sickness absence. So are people tending to call out more often that are experiencing these PTSD symptoms or experiencing low grit or resilience? And I'm sure y'all can think of some others.
I thought one thing that was particularly interesting about their results was when they put them into context, they said that the mean grit score for this population was similar to the grit score for the general population, which these were pretty seasoned. These are 84, and most of them, 84 people, and most of them were pretty seasoned paramedics who've been on the job a long time. It would be really interesting to do this again in either another agency or maybe a national survey to really get that number, because if really seasoned paramedics have a grit score that's equal to the general population, I'd wonder what EMTs and those newer to the field, how they rate. I don't necessarily believe that they have less grit than the general population, but that's something that you could take away from this.
Certainly. And we have a great question here I do want to acknowledge, and maybe we can end with this question and just give some tips from all of us on how we would start some studies like this. So this question's from Rocio from Quito, Ecuador, and we're talking about how to start a study like this. So, you know, in Ecuador, perhaps this kind of a study hasn't been done. How would we recommend getting started with a study like this? And, you know, what are some things to keep in mind?
So absolutely, like we mentioned before, starting with validated measures that are accessible is a great way to start. If you don't have to reinvent the wheel, don't. You can find measures that have already been validated using other populations, and then you can compare to that population. So doing some research and seeing what's available, I think is a good way to start.
Yeah, I think also my advice is to pick out the measure that matters. So, pick out your outcome measure. That might be this PTSD scale. You might have another outcome measure that happens. PTSD is a pretty severe outcome. Perhaps we want to look at something that might happen before PTSD occurs. So there's depression, anxiety, and stress scale, and there's burnout scale. So pick your outcome and then pick a couple of predictors. Tony and I talked earlier about how important it is to have a short survey instrument that really will help the validity of your study. You'll get better response. And then I'll let Bill and Mike comment. Any words of wisdom for somebody starting this kind of study?
I think you've highlighted it. There are a number of tools out there. There's a Connor Davidson resiliency assessment tool. There's the PR6, the Personal Resilience 6 tool. There are studies, there are tools that look at, depression, anxiety, suicidal thinking. So really familiarizing yourself with the tools that are available, understanding which ones you have to pay for and not have to pay for. And I think there's huge value in really collaborating with other researchers in other places. So, I think one fabulous thing to do is to reach out to the authors of this study, to just kind of learn from them about what they were thinking, what they looked at, what they considered, so that it can kind of inform your work, and we're kind of reflecting and building on each other's science, as opposed to just kind of inventing something new yourself.
I was going to say that, Mike. I think it's very important. Studies like this need to be replicated. The things, though, that would come to my mind would be potential cultural differences. If we're dealing with another country or part of the world, that would need to be taken into consideration. And then the language, to make sure the questions are asking are similar, because things don't always translate directly from one language to the other. But repeating studies, people often fail to see the value of having this was a great study, and here's a larger number to it. So I think that would contribute considerably.
Most definitely. I think the selection of a study population is really important, and noticing these potential differences in culture. And a lot of these instruments are already available in Spanish, but checking that translation did in fact capture the same essence in the other culture would be important. I think we're reaching the end of our show, but this article has really convinced me that grit is something positive, and it's something that we can measure. And as the saying goes, if you can't measure it, you can't improve it. But in this case, we can. So this is something that EMS should keep in mind and should be monitoring at our EMS agencies. I think this work has also highlighted a place where we need additional research. We need to identify modifiable factors that are related to teaching or increasing grit in the population. So with that, I really want to thank all of you. Thank you, Bill. Thank you, Mike. And thank you, Tony, for being here. And Dave's still on as well. Thank you.
Thanks for having us.
Absolutely. So as a reminder, just to the listeners, remember to join us for the Education Research podcast that happens later this month. That's going to be on Friday, November 22nd at 10 Pacific, noon Central. And as always, we're going to be back here with our next clinical podcast on the second Monday of the month, November 11th. So thank you all again. Happy Veterans Day. Join us next time.
Thank you.